Good afternoon, good morning, wherever you are. Hello. We're just gonna give participant 2 more minutes, and then we're going to get started. All right. Just to get us started, as an introduction, my name is Benjamin Kagina. I am the director of NITAG Support Hub, or NISH, which is based at the University of Cape Town in Cape Town, South Africa. Welcome to this webinar session. And for those of you who may be joining us for the first time, NITAG Support Hub, or NISH, is a project that is mandated to give scientific support to NITAGs. And these are the National Immunization Technical Advisory Groups that provide guidance to the Ministry of Health on matters related to vaccines and immunization. So what we've been doing for the last 5 years is, in collaboration with WHO, we've been hosting webinar sessions on very specific topics that are topical on the matters that we are facing on the continent related to vaccines and immunization. So this is our 18th webinar series, and we're very excited to welcome you all to this. So just very quick in terms of logistics, if you go to the bottom right on your screen, Zoom, you will see an icon of more where you can click the language of your choice. We do have interpretation, which is AI enabled. It's not perfect. We've been trialing it for the last couple of webinars, I think about 5 now, and the feedback has been improving over time. So we want to continue testing the efficiency of this AI-enabled interpretation. So for today's webinar series, the topic is mathematical modeling for new TB vaccine decision-making in Africa. And really, this is a very exciting time for TB vaccines. And as a continent, we do have a quarter of the TB cases. So this is pretty much the right continent where we need to be quite proactive in discussing matters related to TB and the vaccines and any other tools. And one of the tools that we need to speak about, importantly, is the mathematical modeling. And it is a tool that NITAGs have indicated to us they would want to use it more often in their decision making. And this is the rationale for this webinar session. We want to hear more about TB vaccine development, how far are we, and also what can mathematical modeling do to aid us in combating the TB disease in our continent. I'm very happy with this lineup of speakers and moderators that we have. And we're going to hear from them, starting with Dr. Alexander, who will introduce himself and take us through about the TB vaccines in Africa. And just to mention that, please, as the presentation proceed, if you have a comment or question, there is a chat box that you can put your question or comment. And also importantly, we want this webinar to be interactive and have discussions. So let's hear more about your comment, your questions also during Q&A. With that, I will hand over to Alexander, who is going to introduce himself and then take us through his presentation. Thank you so much, Alexander, and over to you.
Thanks very much for the kind introduction, Benjamin. Very excited to be here. It's my first time. Really thrilled this seminar series exists and excited to talk about modeling. I think my task here is to simply give a brief introduction on the topic of TB vaccines. So I'll try to do that in the next 20 minutes. Can you see my slides okay?
Yeah, we can, but it is. Do you want to put it on the presentation mode?
I see it's back to presentation mode. 1 sec.
Perfect. Just now put it on the presentation mode. We see.
You told me where to do it. 1 second. Video.
Salim is suggesting perhaps you try to swap display if you are using two screens.
It was in the top left corner, right?
Yeah.
Yes, once it's in presentation mode at the top left corner.
Oh, I see it. Go to presentation mode first.
Back where?
Yeah, now I see it. Is that better?
So that's it.
Okay,
Good.
Thanks so much. Apologies. All right, I have a good number of slides, so I'll go fairly quickly, but do stop me if you have questions. Talk briefly about, briefly to my background, I'm a pediatrician and I worked in vaccine development most of my life. At the moment, Deputy Director for TB Vaccines R&D at the Gates Foundation. Prior to that, I was the Chief Medical Officer and Head of Development at the Gates Medical Research Institute, who is developing the M72 vaccine. So briefly touch on epidemiology. I'll mention the guidance documents that are relevant for this, and then talk about opportunities and challenges and present two vaccines that are in late stage development. One is MTBVac, that's a live attenuated vaccine developed by BioFabri, a Spanish pharmaceutical company that's in phase 2B. And then the Gates Medical Research Institute program on M72 AS01. That is an adjuvanted subunit vaccine, and that's currently in phase 3. I'll summarize what evidence will be available at the time of first dossier submission and briefly touch on evidence gaps and considerations for vaccine introduction. In terms of epidemiology, I think there has been decent progress over the last 10 years. Here you see the reduction in the incidence rate, new cases per 100,000 by country, and you can see that many African countries reduced the incidence of TB by up to and above 50%, but it differs quite significantly country by country. This is from the Global TB report. Here on the left, you see that same slope over the last 15 years. So there is a decrease, but the incidence clearly is way too high, and the burden is still quite significant. The dashed line on the left is the target for 2025. So I don't think we'll reach that target, or it hasn't been reached. On the right, you see again the incidence rate per 100,000 population. And the darker the green, the higher the incidence. So really, the global TB burden is to a large extent a burden in Africa and in South and Southeast Asia. Here are the absolute numbers by country, which basically is the incidence rate per 100,000 multiplied with the country's population. So India shows up as number 1 there, and then you see Indonesia, the large countries in Asia, leading, followed by the most populous countries in Africa, like Nigeria. but the incidence rate, for instance, in South Africa is one of the highest globally. So what does this epidemiology mean for vaccine development? On the left, I just want to emphasize that infection and reinfection is quite frequent, depending on the setting. It can be 3 to 5%, sometimes even higher than 5% per year per person. TB isn't as infectious as many other diseases, right? You do need to spend significant time together to transmit. And most people who get infected with MTB do not get ill. 95% of MTB infected people manage the infection and do not become ill. Those who become ill, and that's more common in the first 2 or 3 years post-infection, if you don't get ill in the first 2-3 years post-infection, chances are you won't get ill for a long time or not at all. On the right, I listed the most important known risk factors for development of disease. Leading there is undernutrition, with probably 1 million attributable cases, then diabetes mellitus, HIV infection, of course, alcohol use, smoking. It is the classical disease of poverty, and when we did epidemiology studies, even over a kilometer or 2, you see very large changes in incidence rates, and it's always, or typically, the poorest in poorest housing and the most crowded condition, where the above risk factors add as well that are most affected. There are 2 guidance documents that I think are relevant for this discussion. The first on the left is the preferred product characteristic. That document is a little bit older. The one on the right is quite recent and is probably has the most up-to-date info on policy considerations. And I'll refer to that in a little bit more detail. Just want to be clear, we're talking here about prevention of disease vaccines for adolescents and adults. That is the top priority for WHO based on modeling, because the prevention of disease vaccine will have more impact and faster impact than a prevention of infection vaccine. And because only 5% of people move from infection to disease, establishing efficacy for prevention of infection really doesn't allow you to extrapolate to efficacy for prevention of disease. So we do need efficacy trials with typically pulmonary microbiologically confirmed TB as a primary endpoint. And that makes these trials quite large and complex because the endpoint is not very frequent. Here is an extract from a table in that evidence considerations for TB vaccine policy. I just wanted to highlight a few points on the left. So topic 1.1, just to reiterate, the indication is prevention of active pulmonary TB disease. And then below in the red box, that there is agreement with this WHO working group that for IP stands for Initial Policy Recommendation. For the Initial Policy Recommendation by SAGE, safety and efficacy data in adults with evidence of prior MTB exposure is what's needed, and that's how the trials are designed. So when we say evidence of prior exposure, we're generally talking about the interferon gamma release assay. And so the primary endpoint is determined in IGRA positives, and I'll touch on that later in the talk. Just to explain why the trials are done in adolescents and young adults, if you look at the left, the incidence really picks up once teenagers start mixing more and spending more time together, so say from the age of 15 in very high burden settings. And then it stays quite high for males, they're depicted in orange here. And for females, the incidence starts declining once they get into their 20s and 30s. But of course, that differs greatly by country, by setting, by city, by neighborhood. The higher the force of transmission, the more disease you see in the young adults. So I think the medical burden is quite clear. 10 million people per year fall ill, more than 1 million die every year. And there are many modeling studies. I referenced one here stating that a vaccine for adolescents and adults with 50% vaccine efficacy for the prevention of disease would clearly increase health equity. It would lead to increased productivity and economic growth. And if it costs $4.60, it would be cost effective in the vast majority of low and middle income countries, and cost saving in 58 of 105 LMICs, including 96% of countries with the highest TB burden. And you can see here the calculated monetary return. So the return on investment seems a fairly clear case. Here, with these assumptions, it's $7 per dollar invested. The trouble is, because it's a disease of the poor, there isn't a lot of investment in pharmaceutical R&D. In terms of challenges, I think one of the biggest is that we don't understand the biology well. We don't have correlates of protection, like neutralizing antibody titers for COVID or HAI titers for flu. It's likely a T-cell mediated protection is dominant, and we're working on establishing correlates, but that's years away, and will not do away with clinical endpoint trials in the near future. We don't have a good animal model. I talked about the low rate of progression and the low incidence rate of disease, which makes for large clinical endpoint trials. And because there is no dual market, there's no market in high-income countries, there's limited investment in pharmaceutical companies. So the two vaccines I'll describe briefly are MTBVAC, a live attenuated MTB strain, and then M72AS01, an adjuvanted subunit vaccine. MTBVAC is a Mycobacterium tuberculosis, a human strain that's been attenuated with 2 deletions. The vaccine is now in phase 2B, and I'll briefly describe that phase 2B trial. It's called the IMAGINE trial. It's a double-blind, randomized, placebo-controlled study to evaluate the efficacy, safety, and immunogenicity of the vaccine against TB disease in baseline IGRA-positive adolescents and adults aged 14 through 45. The sponsor is IAVI, the manufacturer is Biofabri in Spain. The study will enroll approximately 4,300 IGRA-positive participants, randomized 1-to-1. Protocol was amended recently to add 1,200 IGRA-negative participants to be randomized 2-to-1. And as I said, for people who aren't familiar with the IGRA is tests immune memory or reactivity to a peptide pool for 2 MTB proteins. So it's a sign of MTB sensitization. It doesn't tell you whether you're currently infected. You can have TB and be IGRA negative. It just tells you there is an immune response, and it's based on the production of interferon gamma. Some people don't make gamma, so they are infected, but they're IGRA negative. The primary efficacy for this trial is bacteriologically confirmed pulmonary TB in the IGRA-positive cohort in the modified intention to treat analysis. And this trial is event-triggered. Once 35 cases of pulmonary TB have been confirmed, it will be unblinded. The assumed vaccine efficacy is 65%, and the lower bound of the 95% confidence interval is 0. There'll be a futility analysis and a second interim analysis, and we anticipate results in 2028, but of course with the uncertainty around accrual of cases, incidence rate versus efficacy. In addition to the phase 2B trial, there's a phase 2A trial in people living with HIV that is run by the HVTN. Sponsorship went from NIH to Fred Hutch. It's funded by the Gates Foundation and Open Philanthropy or Equitable Giving. And yeah, there were some delays. That study will enroll 276 participants, 12 to 55 years of age. And then in addition, in collaboration with Bharat Biotech in India, there's a 2A trial in India in HIV-negative adolescents and adults. And potential phase 3 trial is being discussed between Biofabri, Bharat, and the Indian Council of Medical Research for a phase 3 in India. Now over to M72AS01. As I said, it's a subunit vaccine that's adjuvanted with AS01E. The protein part expresses is a fusion protein, 2 open reading frames from MTB. And the adjuvant, many may know from RTSS or from Shingrix. This is the only vaccine where we had a successful phase 2b trial that was published in 2018. The primary efficacy readout was 50%, and I'll have some details here on the next slide. So in the red box, that is the first case definition. Everybody who had suspected TB had 3 sputum samples collected, and then every sputum sample was tested by PCR and by culture. So you could have 6 positive tests, but you only needed a single positive to meet this endpoint. If you required 2 positive sputum tests, then we're in the red box. With 2 positive sputum tests, the point estimate for efficacy was 68%. So you see that's quite a jump here. And that's why for the phase 3 trial, we're using this case definition where you need 2 positive tests, sputum tests, to get away from false positive cases. This is the design of the phase 3 trial. It's a total of 20,000 participants. 18,000 are HIV negative, IGRA positive at baseline. 1,000 are HIV negative, IGRA negative at baseline. And 1,000 are people living with HIV of either IGRA status. It's a placebo-controlled 1-to-1 randomized trial, 15 to 44 years of age, 2 doses of vaccine given 1 month apart, and there's a large correlates of protection study that's embedded in this trial. The trial is endpoint triggered. We need 110 cases of lab-confirmed pulmonary TB to unblind. That primary endpoint is established in the baseline IGRA negative, HIV negative, IGRA positive cohort. And the trial is powered to have 90% power with an assumed efficacy of 55% and a lower bound of greater than 10%. The trial is run in these 5 countries. You can see South Africa very dominant here because of the large clinical trials capacity in that country. Kenya, 9 sites, Indonesia, 5, Zambia, 4, Malawi, 2. Enrollment was completed in April 2025, so a year ago, and the trial was enrolled very quickly in 13 months. So at First Dossier, I'm now at the Gates Foundation. I'm not with the sponsor anymore. I shouldn't really speak for the sponsor, but this is a potential content of a First Dossier, of course, crucially the phase 3 trial data. So it was 1-to-1 randomized. If you look at exposure and safety data available, there'll be data on 9,000 HIV negative, IGRA positive, 500 HIV negative, IGRA negative, and 500 people living with HIV. Efficacy, as I said, in the HIV IGRA positive cohort as demonstrated primary endpoint, and then safety and immunogenicity, of course, across all 3 cohorts, and immunogenicity by cohort. The MESA trial may be included in this file, which was a study we did in people living with HIV. 400, so 201 were exposed. And then in the phase 2b trial, 3,500 people and 1,786 were exposed. This is a very busy slide, but I thought it's worth talking about the IGRA because that was given attention in a recent SAGE meeting, and I think I want to caution modelers to do too much modeling based on IGRA status, because IGRA status is not a good category to put people in because it changes over time, and we've seen that in our BCG revaccination study in adolescents, and we've seen it in a large EPI study that will soon be published. So IGRA is a good screening tool to enrich your trial for higher incidence rate of TB, because if you're sensitized or infected, you're more likely to progress to disease compared to people who aren't sensitized or infected, because they first need to get infected, and then only of the infected 3% move on to disease over the next 3 years. So it's the right tool to make sure your trial can be funded and can accrue the cases you need. But for modeling, I just want to state a positive IGRA may suggest prior exposure to or ongoing infection with TB, but it's neither sufficient nor necessary to conclude that somebody's infected. So you can have active TB or latent TB and be IGRA negative. You can also be positive today and next week you're negative. We see a lot of fluctuation in IGRA status in the AP study. And because reversion is quite frequent, it was 40% over half a year in BCG Revax and 11% in the EPI study. People who are IGRA negative today and live in high burden settings may have been IGRA positive half a year ago or a year ago. So they're primed, they're not naive to MTB. And to assume that they're naive, I think, is a mistake. Of course, we expect immunogenicity to differ at cohort level between IGRA positive and IGRA negatives, right? Especially following dose 1, you'd expect less of an immune response in IGRA negatives because a good proportion of them are naive to MTB. After dose 2, that's probably less so, but still we expect to see differences. So for the M72 trial, just a few considerations for the trial. It was critical to get as high an incidence rate as possible so that the trial could read out in 4 years or 5 and not in 10, and that we could raise the funds to run the trial. It's already large, it's 20,000 people. So there are 4 strategies to enrich for high incidence. Enroll adolescents and young adults where we know the incidence is high, and many of these infections are first infections, especially in the youngest. Run it in high burden countries, run it in TB hotspots. So most of the trial is enrolled in the poorest parts of the participating countries and participating cities, and then enroll individuals who are baseline IGRA positive. So we did modeling to look at whether it's feasible to run the trial, including IGRA negatives, but we would have needed 50,000 IGRA negatives, which we assumed would take us close to 4 years to enroll and 6 years to read out, and that wasn't feasible. As I said, we'll have safety in immuno in both IGRA positive and IGRA negative. And then I think in terms of data gaps, I think there is a need to establish effectiveness in the overall population post-licensure. But for that, you need the product license to be used in people regardless of IGRA status or HIV status.
We've done the 20 minutes, Alex, so try to...
Go ahead.
We've done the 20 minutes, but try to...
Yeah, okay, I'll take another 2.
Yep.
Is that okay? So I'll go through this quickly. Licensure could be restricted to IGRA positives, but I think that would be a mistake, and we've discussed this with regulators. I think it'll be licensure that doesn't mention IGRA status. And so that then empowers countries to generate the evidence they need post-licensure. And I think there's evidence from other vaccine studies here. I just mentioned Shingrix, where the same approach was used. You study it in enriched populations, and you then extrapolate to other populations and establish post-licensure effectiveness. So vaccine introduction really is my area of expertise, but you have people in the room and online, like Vasila, who think about this a lot more. It's complex, right? You need to consider programmatic feasibility. It's not your typical EPI cohort. You need logistical feasibility. How do you deliver the vaccine at province level, at district level? You want to see a change in the burden of disease. So yes, it's attractive to first vaccinate high-risk groups. On the other hand, if you want to generate effectiveness data and show that there is an indirect effect that you can reduce transmission, then you need mass vaccination campaigns in defined geographies. And of course, equity, financing cost, and cost effectiveness are critical. Thank you very much.
Great, Alex. You got there pretty quickly. We didn't spill over much. Don't worry about that one. Just so that we get feedback from our colleagues. My name is Fred Were. I am chair of the NITAG of Kenya. They call it KENITAG. Just to KE and then tag. In addition to that, I'm a pediatrician. I teach at the University of Nairobi for my day job. And a few other things that I do that Ben is aware of. So I think let's get on straight to the feedback. There was a hand, I saw one hand from Celia. I would allow Celia to go on as we are having I'm avoiding pronouncing the second name. I could make a mess of it. So Celia? There's an anonymous one here. How can we make sure the assumptions used for mathematical modeling are realistic? Alex, that one?
Do we wait for Sylvia or take this one first?
Yep. Go ahead.
Yeah, I think that is the question for this modeling conversation, right? Because it's obvious there are data gaps. There'll always be data gaps when a vaccine is first introduced. And here, the first introduction will happen in African and Asian countries, right? So for M72, I think South Africa and Indonesia are very keen to introduce. They may be the first two. And when you're the first, and the vaccine is brand new, right? You have the limited data there is from clinical development. But to inform policy, you want modeling, and so modelers will have to make assumptions. For instance, what should we assume? Should we assume different efficacies in IGRA positives versus IGRA negatives? There is no real data to inform that discussion. Yes, immunogenicity will likely be a little bit less in IGRA negatives, but will that make a difference in efficacy? And should you assume that, say, we see 60% efficacy in the IGRA positive cohort, should you assume 60% for IGRA negatives, or 50 or 40 or 0? And depending on what you assume, your cost effectiveness output will be very different. So in the absence of data, how do you make realistic assumptions, and who's brought in to discuss these assumptions? I think that's an important question for this group.
Good. Celia, then, can we unmute Celia? Are we having trouble unmuting Celia? If we have, we could get another question if there's one.
Chair, I see Celia saying it was an error that she raised her hand. So,
Celia, okay. We acknowledge the error. All right, then we have one more from Saja. Saja, I won't have a go at second name. Next time we meet, I'll do better. Yeah, what are the challenges in modeling TB transmission? Alex?
Yeah, good question. A tough one, right? The problem is we don't have the right diagnostics or assays. We don't have an infection assay, right, compared to viremia for HIV. So the IGRA, if you're IGRA positive, you're likely to have been exposed to MTB. But if you're negative, that doesn't mean you haven't been exposed. And once you're IGRA positive, right, most people don't get sick. 19 out of 20 don't get sick, but they get reinfected if they live in a high burden setting. And then if you just stay IGRA positive, there's no metric for reinfection. So this is a classic example of what do you do? What do you model in the absence of data?
Yeah, good. That's the best we can go, but TB has always been challenging, so we're not too surprised. I think there was Vanessa had something. Did you want to say it, or do we read it out for you? Vanessa Mwanga is asking if there is Vanessa? Vanessa wanted if there's a NITAG group in Uganda, and whether she can join. I'm sure there's a NITAG group in Uganda. We interact with them from time to time. I can lead you to them offline. They are very active one. It's I think since 2014 or thereabouts. I've had one till now. I don't know their specific work towards TB, but they do have one or modeling. Any other question?
I see Samuel has one.
Yes, okay.
So Samuel in the
Oh,
current.
Dio here. Dio will have an answer. He's from Uganda, Mundube. Let's sort out Samuel's question, then Dio with hand. I'll let him answer that question about Uganda.
Thank you, Fred. I hope I am audible.
You are.
Yes, I will answer the question after I ask my question.
Okay.
So thank you for the presentation. My question is to do with IGRA positivity in the era of low and middle income and our Africa-related countries. We do see significant positivity rates within health workers and patients, although they do not present with any kind of symptoms. When you are looking at the mathematical modeling of a TB vaccine, would there be specific risk groups that you would consider? And that's my question. And that's to Alex. And then to answer Vanessa, yes, there is a Uganda NITAG. I'm a co-chair. I think we can follow up with the Secretariat for any discussion around participation in the Uganda NITAG. Thank you.
No, thanks very much for the question. It's an excellent question. But modeling is supposed, or ideally will help decision makers to make the right decisions. But I think the decision makers need to inform the modelers what it is they could potentially do, or what are the options, right? And I think Vasila and Prof. Njeka have thought about this a lot. Prof. Njeka had an excellent slide at a meeting in Johannesburg last July, listing the high-risk groups and then listing how populous there are for South Africa, right? So people living with HIV, healthcare workers, people living in deprived conditions in slums, people with diabetes. Because, right, the risk, if, say, healthcare workers, we know their risk is elevated, but they're a fairly small slice of the population. And then undernutrition isn't as prevalent amongst healthcare workers, for instance, compared to people who live in deprived conditions. So you need to know both, right? What's the size of that at-risk population and what is logistically feasible? The vaccine is most likely will be indicated for people 15 years and above, and not mention HIV status or IGRA status. So you could do school-based campaigns in 15-year-olds. They're reachable, right? So I think first the decision makers need to think about what is feasible. Of course, they need to know how much will the vaccine cost and how do we get it. But it has to be based on local context and local feasibility considerations.
Yeah, you're running pretty good short of time. Ben is going to shut me down shortly. Any other question on that side? There is used to first been out. Sam.
Yeah, here from Sam's question.
It's
So
sorted.
the modeling to date didn't differentiate efficacy by whether you're IGRA positive or IGRA negative. And I think for the vaccine to be rolled out, right, an IGRA test is not feasible. It's too expensive and it adds a visit. So yes, the intended use is for the vaccine to be given to everybody who's at risk. And in a high burden country, that could be everybody in a given age bracket, for instance. Or it could be focused on high-risk groups. But if you made IGRA status a requirement, you basically decided not to use a vaccine.
Okay. Ben, we were squeezing time. Can I assume that I could hand over to Mama Mpudi and maybe keep collecting some of these questions at the end if you can buy some time? We'll see Alex.
Yeah, I think that's a good decision, Fred. Let's hand over to Mama Pudi.
Okay.
Thank you so much.
Okay. Am I audible?
Yes.
Okay. I'm going to share my screen. Is it showing? Is it showing? Yep.
Not in that format yet. Yeah, it is
Yeah.
now.
It's good.
Okay. Okay. Cool. Thank you so much for the opportunity to talk today on using modeling to inform decision making, especially for TB vaccines. As introduced, my name is Mamapudi Kujani. I'm based at the Health Economics and Epidemiology Research Office, which is based at the Wits University in Johannesburg. So just to start off, I think Alex has laid a good foundation on the epidemiology of TB and some of the challenges in terms of reaching the milestones that we're working towards. And as highlighted, the African region still has a huge burden of TB, with countries like South Africa, Nigeria, and DRC leading with the burden. And in terms of our 2025 milestones, we were far from reaching those. So that's quite bleak. With about 40%, we've only reached about 40% reductions in death, and the target was about 75%. And incidence reduction was about 50%. Well, about 28%, and the target was 50. And we're still behind with reaching the target for ensuring that TB families don't experience catastrophic costs or economic burden due to the TB disease. And in terms of our prospects of meeting the TB targets for 2035 also don't seem as that we will reach them, especially given the trajectory that we are on. I'm showing on the right is this modeling study. It's a bit outdated, but it showed how we are far off reaching the TB targets given in the trajectory that we're carrying. But in recent years, if we have more development in new tools such as near point of care diagnostics, treatment of improving treatment of TB disease, and also new tools such as vaccines, we may get there. But it's still questionable if we would reach these targets. So briefly, as Alex presented on the vaccines, I'm showing the TB vaccine pipeline, which is as of 2002, as of this year in January, we have about 4 trials in the phase 4, in the phase 3 stages, and one of them were what Alex talked about, the M72, which is a TB, a prevention of disease vaccine. So these are the tools that we're looking forward to having results and have them implemented in the next few years, and hoping they will curb the TB trajectory. So with modeling, it comes as a bridge between the trials and trying to extrapolate the impact to a population level, as described earlier. So essentially, we're trying, with the use of models, we're trying to simulate how the TB disease will propagate or spread in the population, and how it would respond to interventions such as a TB vaccine or other interventions that exist in the TB in the health system, like prevention, other prevention measures, diagnostics, and treatment. And we can build models that include both the transmission dynamics and the economics, so incorporating costs, so that we can answer questions of impact on TB disease, mortality or new cases, and also morbidity measures such as disability-adjusted life years. And we can also estimate the overall impact of costs or the budget required and the populations that need to be targeted And usually these will be given by stakeholders. It's not only the role of the modeler, so it would require engagement with some stakeholders such as yourselves involved in country TB programs and immunization programs. And also we can also show the impact that a new TB vaccine could have on the demand or of health services required downstream. So if a new TB vaccine is implemented and it's effective, we can reduce requirements in diagnostics and treatment because we have prevented TB disease propagating. And so just to bear in mind is that models do not accurately predict the future, and it's always for our responsibility as consumers of models and us as modelers is to make it explicit the assumptions that we make into developing the models, be explicit about the input data. So some of the information that Alex was also describing, some of them we don't have concrete evidence as it stands, but we have to make some key assumptions. So in interpretation, we have to always bear in mind that the results are within those uncertainties. And also, some of the simplifying assumptions and also the key limitations about the data. Just following on this. So with TB vaccine modeling, some of the key considerations are, which is important, is the TB natural history. So how are you going to represent TB? Are you going to be explicit in all the disease states that exist and what informs them? And where do you get that data? There's always some uncertainty around how people move between states, as described earlier. If you were to describe a person to be latently infected or to have a positive IGRA status, they can progress or stay there. Do you account for those dynamics, and where do you get that data from? The other key input is the vaccine efficacy. So as also shown earlier, the main one of the commonly cited trials for the efficacy that we use is around 50%, and that relies from the 2018 study that showed from the M72. But what we have to bear in mind was that it was it's a prevention of disease. It was over about 22 to 3 year period, and it included people without HIV and people with a positive IGRA status. So when we do modeling, we do make some assumptions that are not similar to that trial, so that it's some source of uncertainty, so that we need to bear in mind. Other key assumptions is that what is the mechanism of action of efficacy for the vaccine? Is it a prevention of disease or prevention of infection? And whom is it administered to, as described in detail? So if you're going to administer it to people with infection, are you going to do the test? And that's adding expense. So most of the time in models, we just say to everyone. And the duration of protection, usually we in modeling, we assume a longer period, but then in the trials, it was much shorter. And so that introduces some level of uncertainty with our estimates. And then also the data that informs the model. And this is very important for our models to be representative of our country estimates. They have to be calibrated or fitted to country-specific data. This is a process where you try and match your model estimates to observed data. and to ensure that it represents what is actually happening in the country. And it's usually always ideal to use country level raw data, such as mortality, for instance, mortality data from the vital registers, TB prevalence survey data, lab testing data if there is, and TB notification data or treatment registry data. And in the absence of these, so the WHO TB estimates are also used as calibration sources by others as model estimates. Bear in mind. So a few studies have been, a lot of modeling work have been done previously to estimate the impact of a new vaccine, and some of these were also described in, for instance, the TB investment case that Alex described into detail. I won't describe into detail here, but the general consensus is that a new TB, an effective vaccine in adults will have, in adolescents and adults, will have a substantial impact on reducing mortality and impact and morbidity, and it would have a return on investment. So I will just briefly, I will just go through some of the ongoing work from a study that is also Wellcome funded. The effort here is to also generate modeling evidence to inform decision making. So as described, so I just mentioned, so these are the typical processes that we go through when building up a TB model. So we represent the TB natural history. So this is the LSHTM model that I'm using. It's a model that simulates how TB transmission goes through. So these are the key assumptions that we assume in this model. We assume that a vaccine would have 50% efficacy, and it is irrespective of individuals' infection status. So we don't do a test whether someone has infection or has a positive EGRA status, and we assume that it is a prevention of disease, and the vaccine reduces progression to disease. So this is how the mechanism of action, and the protection duration is around 10 years. The duration of the model horizon, so the period that we assess impacts over is around 20 years. And then we have on the vaccine itself, and I'll describe these in the next few slides. We went through stakeholder engagements, and that was part of the study to inform us on the coverage of the TB vaccine that is deemed feasible, and the delivery strategies and the populations that need to be targeted. To incorporate costs, we also used some data from HERO, which is about the TB program costs from diagnostics, treatment, and prevention, and also the cost of the vaccine, but it's based on old studies, so that's not the actual price of the vaccine. And the model is calibrated to WHO TB estimates and HIV estimates from the UNAIDS. So just to go through some of the stakeholder information, and how they engaged this. So this was a part of the bigger study in the WellMod study, where they engaged different stakeholders from South Africa, from the Department of Health, from the regulation bodies, the Gates Foundation, some civil society, and TB research body, the TB research community, to give us information on what they think would be key factors that influence a successful rollout of a TB vaccine. And as you can see in the circles here, it's the key factors that would be considered. So efficacy, price, operational requirements, vaccine schedules, that the trials are conducted locally, and the impact of the vaccine, and also the cost and the cost effectiveness. So the important part for modeling input was this part that we would use in the model, and I think someone also asked about it in the discussion earlier. So some of the key populations that were identified through that process were, and we were told by the stakeholders, were that targeting adolescents and for different kind of strategies. For instance, for campaign, it could be between 50 to 80%, a mass campaign approach, and a routine approach strategy could be about 60 to 90%. So same for other populations, for people with HIV, healthcare workers, and adults was also one of the identified key populations. And as we can see, pragmatically, so some of these populations could be easy to reach. For instance, adolescents who are school going, but adults would be challenging to find them. But people with HIV would be easier to reach them through their routine care for, or seeking care for collection of ARVs. But for healthcare workers, it could be easier to also identify them, but it's also a small population it's a small group in the population, as we discussed earlier. And some of the inputs that we considered for the costing, just quickly to illustrate, and I'll show a few results that we can discuss. So, for instance, the cost of a vaccine itself, we don't have the data on the price yet. At the moment, we are relying on previous people's work. So this is the estimate that we are currently using. And then other program costs that we include are like screening and testing, treatment, and for drug resistance and drug susceptible TB. And as we know, drug resistant TB is one of the most expensive, it contributes to the most expenses in our TB programs. So these were just showing the estimated impacts of the different delivery strategies. If we're targeting, say, adolescents, this is the population impact it would have. For adults, only 18 to 64, and for all adults, if we're looking at 15-year-olds, say, to 90-year-olds, this is the impact it would have. And for people with HIV, and the general message is that it would, if you're targeting a broader population, that's where you would have more population level impacts in reducing TB incidence and mortality. For instance, in the all adult strategy, it could reduce by up to 20 to 27% in incidence, and about 20% for mortality. Another thing that we can show is that downstream, some of the health services required would be reduced. For instance, this figure shows the number of services required by treatments or tests and vaccines. So obviously, if you are going to invest in a vaccine for a broader population, that's where you'd have to spend the most money. But downstream, we can see that the costs for treatment and testing eventually decrease, especially for the broader for the broader groups, like the all adult strategy. and for adolescents compared to if we were looking just a small population like PLHIV. And similarly for costs, so it is expensive for the all adults strategy to target a broader population compared to the other populations such as PLHIV or adolescents. But downstream, it has relatively saving costs in the other aspects of the health system. And overall, it does have a large population impact in reducing both TB incidence and mortality. So I'm not showing the incremental cost effectiveness because this is just preliminary work, but this is ongoing work that is in progress. So in the later in the year, would have all the full analyses. But the general consensus from the modeling itself, from this work and other modeling work that has been described earlier, is that greater impact, population impact, is when targeting the broader, so more adults and adolescents. But as we could see, it would cost more. Targeting people with or high-risk groups strategies. So for South Africa, the main target is PLHIV because that's what our main risk group. But for other countries, they could target their main risk groups. That would be a more efficient way because you would reach those who are likely to get TB, and it would cost less, but it would have a minimal population level impacts. Another high-risk group that was previously shown was in minors. And some of the
just another minute or two.
Okay, yes, I'm closing. Just to highlight some of the gaps that exist. So one was just highlighted by Alex on the issue on latent TB status or IGRA status, that it's we don't have a certainty how efficacy varies by status, and a lot of modeling needs to be done to kind of understand, and more empirical studies need to be done to understand that. And some of the data that is required, and I think is still going, is on the different delivery strategies, and also which groups to target best, although there is indication from modeling studies. And there's also ongoing work on how best, or how will the vaccine be acceptable, because that will also affect the uptake in the future. We cannot assume that coverage will be the same as what the stakeholders have said. Also for the economic evaluation part, so we would need to also account for the costs of the different delivery strategies, how they will be implemented within existing TB or health systems. And to be able to secure a new TB vaccine, we should have to show how it performs relative to other in TB interventions in the form of investment cases. So this would be work that is required. And as mentioned, there's always need for local data, and more granular would be ideal, but we're still getting there, as in like subnational modeling, and also local and country level driven modeling is what is required. Yeah, and so just to conclude that modeling is a valuable tool to inform decision making and vaccine planning, and a collaboration between the NITAGs and policymakers is required and an essential step at this. And the use of local data would be essential, and also ensuring that we build local capacity and support our NITAGs within the region. Okay, thanks.
Thanks so much, Mamapudi, for that excellent presentation. I'm moderating this discussion. My name is Wasila Jasad, and I'll be presenting next, and I'll tell you a little more about myself then. Let's see. I didn't see any questions or any hands up. Do we have any questions for Mamapudi, Salim? All right, so we have a question from Brian on coverage targets. What is the rationale for projecting a higher coverage for routine compared to campaign? It seems to be the opposite in most cases, higher coverage through campaigns compared to routine delivery. Mamapudi?
I could throw that back to you, Wasila. You're one of the people who are choosing this. So, for instance, are you talking about, say, for adolescents and HIV, or in general, I guess that's what's the case. I think it was also that for routine, it's for one in the way we were looking at it. So if it's routine, it's to a specific age group. For instance, for adolescents, the routine when it's scaled up at 90%, or it would be to 12-year-olds only. So it makes sense to try and reach the most. Whereas if it's mass campaign, you're trying to reach a broader age band, and that goes to the same to the other groups. I don't know if it makes sense, and if you have anything to add.
Brian, I'm sure you want to add, but I think what I understood is, you make an assumption that you would get a higher coverage through routine immunization compared to a campaign. Is that an assumption in the modeling?
That is what was informed by stakeholders. So the stakeholders gave ranges for, say, for adolescents. For routine, they said it would range from 60 to 90. For a campaign, it ranged from 50 to 80. And yes, so that is the assumption that we use, but it was informed by the stakeholders. And my thinking is it's because that it is sustained in a smaller population for a longer period. I don't know if that makes sense.
Thanks. We have another question. Have you modeled vaccination campaigns in large urban, peri-urban areas to estimate the effect of vaccination on MTB transmission, the indirect effect?
No. So what we don't do is a disaggregation of the population by subnationally. So everything is just at a national level. So hopefully in the future, when we have subnational versions of our model, we will be.
Thanks. Sheetal, you wanted to add, I think, on the question of the coverage that we reach through routine and campaigns.
Thanks, Wasila. I just made a comment in the chat that it's gonna the question on the coverage will really be country dependent and also dependent on the delivery mechanisms and the time in which you're able to actually execute campaigns versus routine. So this is another call, as Mamapudi put forward many times, on the importance of taking into account local context when doing models as well. Thanks.
Thanks for adding that. Final round. Do we have any other questions, Salim? All right. If not, then we'll thank Mamapudi for an excellent presentation and making very complex kind of ideas easier for us to grapple with. So we're going to move right along. I'll be presenting next. Just bring up my slides. All right. So my name is Wasila, as I said. I work in the TB Control and Management Cluster in the National Department of Health in South Africa. And I also am a member of NAGI, South Africa's NITAG, where I chair the TB Vaccine Working Group. And so I think Alex and Mamapudi have done a good job of laying a good context for what I'll be talking about. And so we've heard how, of the promise of UTB vaccines and where we are and what are some of the challenges in trials. We also heard about the use of modeling data and its importance for TB vaccine trials and evidence. And so I'll be talking about what our NITAG is doing and in terms of how we hope to use modeling for an evidence to recommendation. So South Africa's NITAG is called NAGI, the National Advisory Group on Immunization, established in 1993 with 14 current members. We have 10 working groups. And as I said, I chair the TB vaccine working group, which was formed in June 2024. And of course, NAGI uses all manner of guidance from other bodies, including WHO SAGE, the Global NITAG Network, and the RITAGs. These are all important for the work of NAGI. So the steps towards decision-making essentially uses evidence to recommendation framework, relying on the grading of recommendations, assessment, development, and evaluation. And, quickly, just to go through our steps, we clarify the scope and agree on a question, develop a PICO, the population intervention an outcome. We always think about the perspective, whether it's a public health or programmatic versus individual or clinical outcome perspective. We look at what reviews and evidence are needed, which resources are available. We agree a timeline. We complete the evidence to decision table. And then with discussion in the technical working group and the broader NAGI group, we reach a decision and make a recommendation to the government. So these are some of the recommendations NAGI has made over the past 2 or 3 years. You'll see recommendations around oral poliovirus, cholera virus, HPV, Mpox, COVID-19, RSV, and a catch-up for measles, rubella. And we do use modeling. In fact, and just to give you 2 examples, for making a recommendation for COVID-19 vaccination, we use cost effectiveness and epidemiological models to establish the cost that could be averted by introducing the vaccine, plus the cost of that it will cost us to roll out the vaccine. And similarly, for the RSV recommendation, we used cost effectiveness analysis to define the price threshold, including procurement and distribution costs. And we also did a budget impact assessment to look at the costs of implementation again. So that's how NAGI works. And maybe to just touch on TB and the TB burden in South Africa, if you compare in 2024 the global burden with South Africa's burden, you will see quite alarmingly that TB incidence in South Africa is 3 times higher, with MDR and incidence 4 times higher than the global average. And the mortality rate in South Africa is over 5 times higher than the global average. And with current interventions, we believe they are insufficient to meet the 2030 goals. Mamapudi shared a little bit of this with you, and we're looking keenly at modeling evidence for TB vaccines and data coming out of early trials. And what we're seeing is that a 50% efficacious vaccine could prevent TB cases and deaths in South Africa and would be cost effective and even cost saving. So given that there's an urgent need to implement a TB vaccine in South Africa because of the burden of disease and because of encouraging early evidence, I thought it was important to think about how we would incorporate modeling in the framework that NAGI uses to make a recommendation. So the grade domains include the priority of the problem, the benefit and harms of the intervention, the values and preferences for target groups, the resources that would be required, and the cost and cost effectiveness, and then any impacts on equity, whether the vaccine would be acceptable, and feasibility of implementation. And I would argue that, modeling makes a big contribution in all these domains. So for the first one, whether it's a priority, we know we have clinical data, we know we have, TB program data, but what modeling is able to do is to integrate notification data to project future TB trajectories if no new action is taken. And I think Mamapudi showed that well. And this will help the NITAG establish the urgency and scale of the need for a vaccine. In terms of benefits and harm, modeling data will translate trial efficacy into population impact. And again, Mamapudi showed you some examples of that. And that will really define the public health value and the strength of the recommendation. Similarly, for values and preferences, modeling can simulate the reduction in catastrophic costs for household if we prevent TB cases, and that might assure alignment with community priorities in making those decisions. I think it would be important to have cost and modeling information so we could simulate human resources, supply chain, cold chain capacity, and dose volumes for various rollout cases. And in so doing, it will inform our operational planning and logistical roadmaps for introducing a TB vaccine. I think we can't argue that cost effectiveness data is extremely important and will determine the value for money to secure political and financial buy-in for introducing a vaccine. And equity is very important. Mamapudi told you about some of the different target groups and scenarios for introducing a TB vaccine. And so if we do modeling data that disaggregates impact by age, HIV status, or different target groups or regions, we can see if the vaccine would close health gaps and it would guide subpopulation targeting for high burden geographies. I think acceptability, while there will be some research studies to look at vaccine acceptance, modeling will also help to look at what if vaccine hesitancy and fatigue may impact uptake of a vaccine, and this could help us shape communication strategies and social mobilization efforts. And finally, linked to resourcing, I think if we are able with modeling to test different delivery platforms, for example, school-based versus clinic, we could identify bottlenecks, and that can help us to select the optimal delivery channel for the local context. And so modeling data really takes us from clinical data from trials to population impact and effect, so that we can make decisions about implementation. So now I'll wear jointly my TB cluster, my work in the National Department of Health TB program, as well as my work in NAGI, to talk a little bit about our preparedness for a TB vaccine. So we know that there are many steps from discovery to implementation and sustainable supply of a TB vaccine that can take some time. The WHO have mapped out all the different role players and the actions and activities that would be needed across these role players. And you can see that NITAGs are central, or will play a central role in TB vaccine introduction, because we would interpret global policy in relation to local and regional context to inform policy and introduction decisions, and working with a wide variety of stakeholders. So looking at South Africa's approach, I mean, there's been quite a bit of, activity around global political and strategic commitment where South Africa has been involved. So our Minister of Health is a member of the TB Vaccine Accelerator Council of the WHO, which will facilitate development, testing, authorization, and use of a new TB vaccine. Last year, South Africa hosted the G20 presidency, and we used that opportunity at a ministerial meeting in November to advocate for financing and access for a novel TB vaccine. South Africa also co-convenes the Finance and Access Working Group of the Vaccine Accelerator Council. And one of the outcomes was at the end of last year at the G20 meeting, the launch of a document which charts the way towards sustainable financing and access for a TB vaccine. On the local front, South Africa has included TB vaccine preparedness in strategic and operational plans. Our EPI program is working on launching the National Immunization Strategy, which shifts and transitions from a focus on childhood vaccine to a life course approach, which I think will be very important for TB vaccine implementation, because M72 would be introduced to adolescents and adults. And so I think that this new National Immunization Strategy would be a good test of providing vaccines along the life course. And finally, last year in June, we had a workshop, a country workshop on TB vaccine preparedness, which resulted in a report that captured the discussions at the workshop. And after that workshop, a small group have worked on developing or drafting a country roadmap for accelerated implementation of novel TB vaccines for adults and adolescents in South Africa. The vision of our roadmap is to initiate a nationwide implementation of TB vaccines within 1 year of regulatory approval. We know it's quite ambitious, but we think it's important to have no delays in introducing a vaccine that's shown to be efficacious. We have developed milestones and activities across 3 goals. The first goal is a vaccine must be available. There must be sufficient and sustainable and timely supply. The second goal, a vaccine must be accessible. It must be equitable with affordable delivery to all who could benefit. And the third goal is a vaccine must be acceptable, which is aligned with the expectations of end users and recipients. To achieve that, there's a lot of work that's required both by the TB program, EPI, and our NITAG around coordination. We've got a TB think tank in South Africa that provides guidance to the National Department of Health on matters of TB, and they have a prevention task team that will, coordinate evidence around TB vaccines. We formed the South African TB Vaccine Readiness Consortium, a consortium of academic researchers, policymakers, and other implementation partners that supports a streamlined, evidence-informed introduction of novel TB vaccines, ensuring health system readiness at every level. And this is a consortium where we can debate and discuss and, use as forums to discuss the evidence gaps and the evidence that we are producing that will help inform a recommendation. One of the research studies Mamapudi discussed with you is the WellMod TB. It's a TB vaccine demand and impact modeling study so that we can develop TB vaccine demand forecast and inform health and economic impact modeling. And finally, I wanted to tell you about an initiative funded through UCT and VACFA, the Vaccines for Africa. And it's called Tuberculosis Integrated Model-Based Evidence and Recommendations, which is called the TIMBER study. So it's a NITAG-led co-development of model-based recommendations for introduction and implementation of new TB vaccines. And 3 countries are involved, South Africa, Gambia, and Kenya. And essentially, the investment from the grant is to these 3 countries to have a research fellow support the NITAG and working groups for TB vaccines to produce model-based recommendation. And I think in this way, what we're doing is ensuring that we understand the gaps in evidence, we are doing the research and coordinating the research that needs to be done to produce those data. And then we also are supplementing that with capacity in our NITAG so that we can use the model-based information for making a recommendation. So finally, I just wanted to end on this slide, which is essentially lessons for Africa and thinking about how we chart the next few years. We all agree there's an urgent mandate and a new TB vaccine is critically needed to address the high burden. And we also know that there are often policy lags between interventions and their implementation, and specifically for vaccines. And so we need to mitigate those lags. If we are proactive as NITAG, we can avoid years of delay post-trial results becoming available. So how do we move from trial data, which is talking about efficacy, to population impact, which is talking about reality and implementation? And I argue that we need transparency, collaboration, and regional synergy. And so we need sovereign, country-led, evidence-based leadership for this evidence to recommendation process. We need to embed academic modeling hubs into formal NITAG task teams, as I've shown you that we are doing through TIMBER in 3 countries. And I think we need a real commitment to sharing standardized modeling frameworks and information so that other countries can save costs and accelerate decisions. And just to leave you finally with my thinking that data-driven decisions are the most suitable way to ensure new vaccines reach those who need them most in Africa, and this certainly holds true for the TB vaccine. Thank you.
Thanks so much, Wasila. Thank you for such an excellent presentation. And I was going to also congratulate you and the South African sort of task team on all the preparatory work that has been done in order to be prepared for the introduction of a new TB vaccine. And I also wonder if there will be opportunities in the future to be sharing this this information with other NITAGs on the continent who are also wishing to engage in preparatory activities for the upcoming TB vaccines.
Thanks, Sheetal. I mean, I think this has been a culmination of a lot of work over the past year or two from many stakeholders. I think there's high-level political support for this from our minister. And I think the fact that South Africa is taking these steps well ahead of a vaccine being available points to the commitment that we really do believe that a vaccine could be life-saving. And I think the work of the South Africa's NAGI and the broader TB vaccine preparedness community should definitely be shared. And I think VACFA could be a powerful platform for sharing. I think we could do definitely have a repository for example, our country roadmap and the report of our workshop, country workshop. But I think, whatever evidence becomes available, we should find a way for sharing that and have more webinars as well to be able to share more concrete information.
Thanks, Wasila. And also adding to your last point on your slide about, shared frameworks of models or decision-making pathways and preparedness pathways, I think would also be very valuable to be shared on such a repository. So thanks so much. Salim, do we have any questions? I did note one from the chat. There we go. Thanks. So we have a question, Wasila, from Ngina Masu, who's asking, is the community being engaged as one of your local stakeholder groups, given the levels of vaccine hesitancy that has been previously demonstrated with COVID vaccines?
Absolutely. I think that we are all very aware that, vaccine hesitance has been rising. We've seen in South Africa that in the last few years, even coverage of routine childhood vaccinations has dropped. And so we don't want to do all this work for preparation for a TB vaccine only to be faced with a low uptake because of, concerns. And we know there are many reasons for vaccine hesitance. And so from the earliest discussions we've had, we've included vaccine acceptance as a key pillar of our TB vaccine preparedness. And we've got civil society and community involved at all levels. In our country roadmap preparation, we've got a task force around vaccine acceptance. In our novel vaccine research consortium, we've got a whole work stream around vaccine acceptance as well. And there are a number of studies planned and ongoing around understanding acceptance for a TB vaccine. I know that this is not only happening in South Africa. I think even globally, in terms of preparing for TB vaccines, I think communities and civil society have been included as key stakeholders in thinking through roadmaps for vaccine implementation.
Thank you, Wasila. I think there was just one more question from Brian that you may have answered this already, but just to clarify, Brian is asking, is TB vaccine part of the NITAG, the National Immunization Strategy in South Africa yet?
The National Immunization Strategy is sort of talks about the platform for pivoting from a childhood vaccine to a life course approach. So it doesn't talk specifically about any specific vaccines, but it lays the framework for how vaccines can be introduced, including to adolescents and adults. We have been watching the development of the National Immunization Strategy so that we can plan the TB vaccine rollout with the new structure and framework in mind. So not specifically mentioned in the strategy, but I think the two will work hand in hand in terms of thinking through rollout of a TB vaccine. But good question. Thanks, Brian.
Thank you, Wasila, and thanks once again for your presentation. We have one more question. Excellent. So yeah, we can see this one. Given the global organizations like WHO provide impact and cost effectiveness estimates for new vaccines at the global level, why do we then need to have our own South African investment cases, so to speak, or our own modeling and cost effectiveness analysis using our own local data?
I mean, I think global models are valuable for setting priorities, but they often lack the granularity I think we need for local decision making. And Mamapudi hinted at that as well. So I think we need specificity for our own TB epidemic. We know we have a very high incidence rate. We have a high TB HIV co-infection rate of 54%. And so, we would want to model these particular dynamics in South Africa, especially because of the high HIV TB co-infection and the high drug-resistant TB. And I think also, global cost-effectiveness models will use, global or regional price points. We need to look at South African costs data from, our own labor costs to logistics to supplies, so that we can make, a good budget impact analysis that we can submit as an investment case to our national treasury. And I think also for informing our delivery strategy, local modeling will help to tell us where and how to use it. Should we have a national kind of approach? Should we have a targeted approach to certain high burden groups? Should we have a geographic approach? Should we have an approach that targets school-based vaccination? I think those, the local data helps us to define our strategy more appropriately.
Thanks, Wasila. I think also to add to one of the points you made on the last few slides was that of also equity and taking into account equity considerations. These can only be done in local models with local data. So thank you. Yeah, thank you once again for your presentation, also to the audience for so many questions. So we'll move on to the next presentation then, which is actually by myself. So while I'm getting my presentation set up, let me introduce myself. I'm Sheetal Silal, and I am the director of Masha, which is a Modeling Simulation Hub Africa. So I'm also a modeler like Mamapudi. And what I was going to do, I've been actually editing my presentation as our seminar has been going along, in order to maybe consider some issues we haven't yet discussed. So one of the major points that came up during the first parts of our presentation today was this uncertainty around data, and what assumptions are the models making, and are we wedded to these assumptions, and also the question of can we model when we have so much of uncertainty, and if we don't have this data, where does it actually come from? What do we even do? And so that's maybe what I'd like to reflect on for a few minutes as we come into the last half hour of our seminar today. So when we're building models, you've seen sort of the complex pathways that Mamapudi showed when it comes to doing TB models. We know that at the end of the day, this is how we see disease spreading. I'm just talking general diseases now. So this is how we see diseases spreading on the left-hand side. But actually, what we have to take into account in models is what goes on the right-hand side. What is actually happening on the ground? How are individuals becoming infected? How is TB actually spreading? The different types of TB, immune status, exposure, the diagnostics tools, the different interventions, delivery pathways, all of that individual level context is what we've got to take into account when we actually build models. But as everyone, I think on this call on the seminar has realized, is that we don't have all the data all the time. I don't think for any of the diseases we have to model, we have all the data. But importantly, what I'd like us to understand today is that it doesn't mean we can't do modeling. In fact, modeling will remain one of the only tools that can be used to help us understand the bounds or the range of this uncertainty. So I'm going to maybe just demonstrate a little bit about that using a very simple teaching tool that we've actually developed for other webinars as part of the niche program. And so what I'm going to do is explore using an example of a simple disease X model, where this model is a question that we're trying to answer is, trying to introduce some vaccine, a disease X vaccine into the country. And this this disease has quite a high R0 of around 12, and it confers lifelong immunity. There is a new candidate vaccine, however, and it's in a 2-dose format. The first dose has a protective efficacy efficacy against infection of 85%, and having both doses confers 100% protection. And the recommended schedule from a global authority from clinical trials is at 1 and 2 years of age. So using something as simple as this, let us explore the types of information we as stakeholders in country level modeling will need to decide upon and either collect ourselves or put in new studies to collect this data or make some judicious assumptions. So as we get to let's say a model example like this, you think about the assumptions that we've made and reflect back now on Mamapudi's presentation with the assumptions that she listed and the data sources that she listed. And similarly with Wasila's presentation on the different ways in which modeling can be, different types of questions modeling can be used to answer in terms of cost. And earlier with Alex's presentation on the difficulties of diagnostic assays and what that means for how we count cases or measure our endpoints in modeling studies as well as clinical trials. So we have to make assumptions on how many people are there in our population, our infectivity, how the biological mechanisms will work in our in TB or disease X in our case. What about the immunity assumptions? And then there's also other things that we've got to think about. How do births and deaths interplay with this disease? What are the key age groups we need to consider? Do we judge all the population as one alone, one big group together, or do we have to actually specify that there are different target groups with respect to vaccination, with respect to TB transmission and the development of immunity and so on? With the vaccines, what about the delivery mechanism? What about the cost? Who pays for this? So we've got all of these assumptions to be making, not least of which are things like population access to care. Someone, I think in the audience, had mentioned, what about subnational modeling? We know that health access is not the same in an entire country, and it differs for different risk groups, it differs spatially, it differs by socioeconomic status. So we've got to be thinking about all of these aspects and whether they are relevant to be included in the model. And if they are relevant, where do we get this data from? And sometimes this data does just not exist. And so what I'd like us to see today is maybe have a little bit of a discussion on how we actually deal with this lack of data and how do we deal with so much of uncertainty. And so what I want to show you today is what we do in modeling. So in modeling, as Mamapudi described, you are in fact building a model of not just TB transmission in a setting, but also the health system around TB transmission. So how does the health system react to the presence of TB, and how does the patients and population react to the presence of TB transmission? So when we're talking about the provider or the health system side, we're talking about the health system capacity, the strength of the health system to diagnose, the availability of care, of drugs and vaccine in our case. And on the patient side, we're also then looking at the accessibility of health services to the patient's own individual characteristics with respect to HIV status and so on. And so you're building a model of an entire health system. And with that model, we will then be able to actually use tools like what-if type questions to ask the model to help us understand the bounds of this uncertainty where we have particular data gaps, right? And so we call that a sensitivity analysis. And there's many different methods of how we can actually perform this sensitivity analysis, sensitivity to different assumptions, sensitivity to individual parameter values, but also sensitivity to lack of data or to areas where we have quite a lot of uncertainty, and we want to get an idea of how robust our final recommendations from the model will be in light of that uncertainty. So let me just escape this for a second and show you very briefly in our limited time today. So I'm here at this teaching little app. This is not a TB model. It's just a disease agnostic model. And what we're going to do here is I'm just going to just going to reload the app. And what we're going to be doing is we are going to be running a model here. You can see here it's a model of disease X. We're starting just in 2025. We're starting the introduction. We could start the introduction of a vaccine. Right now, our vaccine coverage is 0% for vaccine 1 and vaccine 2. However, disease is still transmitting, and the population are seeking treatment and actually, or rather having access to treatment at very good high rates of 70%. We also have some cost information here. There's a cost for the vaccine itself, a cost for the delivery, and then also a cost per case treated, and then a cost for introducing the vaccine when the vaccine eventually gets introduced. And what you can see here right now is the way this particular disease is transmitting. We have the majority of transmission occurring in your 0 to 1 age group, followed by your 1 to 2 years. And then as the disease spreads quite quickly through the population, we see that in the older age categories, we have the disease has already spread and the population are protected for the remainder of their lives. So now we could say, for example, let me ask a what if question. What if we were to introduce the vaccine, just the first dose at a 50% coverage? What might that do? Take note of the total cost and just take note of the pattern. So if I were to run that, which just takes about 5 to 10 seconds to run that, what we can see here is that now we have some increased costs from about $5 million to $7 million because you've got to take into account the cost of the vaccine that is administered at the first year of age. And we can see immediately that what that's doing is we can see immediately that there is a drop in our incidence, particularly in the 1 to 2 year age group from vaccine introduction, because we have introduced this vaccine that is now allowing for protection. It's only at a 50% coverage, but it's allowing for protection in this particular age group, which will then age through the population. And we can see that here, as we can see with the vaccine introduction in 2025, our subsequent age groups, the population protected has in fact increased due to vaccination as this population ages over time. But coming back to sensitivity, what if we were not sure? What if we were like, well, you heard, I think Mamapudi say that maybe the routine vaccination is somewhere between 60 and 90%. What if we were then able to increase this to 60 or even 70%? We could then run the model again. Similarly, we could be asking the question, but do you know what? The one thing we don't have a lot of information on is we are not able to really have a good idea on how often people seek treatment for this particular disease. We just have some information from the DHS survey, but that hasn't been done in a while. So actually, we don't have a good idea. You could then similarly use modeling to explore what if my probability of my population accessing treatment was 60%? What if it's actually low? It's as low as 30% in some hard to reach groups, and then run the model again. And so what you can see now is we can do a lot of variation. We could say, well, actually, do you know what? The vaccine right now, it's costing $1.35 to land in the country, but then it's costing my government that amount, and to deliver is 20 cents. It's going to be quite expensive, but what if my vaccines were donated, or we could be negotiating them to be at a much lower price? And you could then test this by maybe reducing this. If you manage to negotiate a lower price of, let's say, 90 cents as opposed to $1.30 or whatever it was, you would then be able to now rerun and each time have a look at and compute the number of cases averted through this new strategy, the number of and the cost associated with it. So what I'm trying to say is that using a very simple tool, just showing you the types that even if we don't have information, on very important parameters and data that is needed for our models, it doesn't mean we can't model. It just means that we can use modeling to explore the ranges that we might want to consider for different risk groups, for different spatial areas, in order for us to understand or bound our expectation and to see how robust our decisions are to changes in our input data.
Just a minute or two, Sheetal.
Yeah, just ending off, thank you. Just ending off to say that we all have a role to play. Whether you are a modeler, whether you are a decision maker, whether you are a researcher, whether you're part of a NITAG, and part of the local public, we are all stakeholders in this in these types of modeling exercises, because we all have insight into these analyses. And so the roles we have to play is in terms of identifying different types of analyses that need to be done and the data that is required. In many cases, we have to ask the question: is modeling the right approach? Are there other statistical analyses that need to be done to enable modeling to be done? Do we need to wait for better clinical trial data to be more certain of certain parameter values? We must make sure that modeling, as another type of analysis, is also subject to us understanding its strengths, its weaknesses. And lastly, just to add that, very importantly, the models can make recommendations. That does not mean that those are the recommendations that a country should follow. As Wasila explained through the grade process, there is a well-detailed process of translation of model recommendations that need to be translated, first assessed for their strength of evidence, and then translated into operational plans in order to develop actionable recommendations that are suitable to individual country needs. And as a last point to say, and this is perhaps a topic for another webinar and further dissemination, is that the WHO has recently released a new guidance document aimed directly at immunization decision makers on the use of modeling analysis and how to translate and engage with modeling analysis in routine immunization decision making. And that will be a resource that I think will be useful to everyone on the webinar today. So thank you once again for your time, and over to you, Edina. Thank you.
Thank you so much, Sheetal. That was very, very informative. I really like the vaccine tool, and I think I speak for everyone else on the call that this is a really cool tool to at least just start playing around, but also really informative in terms of our decision making. So good day to everybody. My name is Edina Mponsa da Costa, and I serve as a Senior Research Officer and Evidence-Informed Decision Making Specialist with our NITAG Support Hub project. And so as we start to check whether there are any questions from the group, I think it's a good point in our session to just thank everyone who has stuck around with us. And perhaps from my end, Sheetal, I'm really thinking about the points that have come up during the course of our session today around sharing modeling evidence to enhance regional coordination. And possibly towards a TB-free Africa. And I'm wondering whether, what sorts of coordinated efforts exist within the African region, including Masha, to better, support evidence generation, modeling evidence generation within the African region. So I guess to simplify, what can our colleagues on the call tap into in terms of resources to enhance their national efforts around TB control and potentially TB vaccine preparedness?
Thanks, Edina. So that's a great question. There are, in fact, a number of modeling initiatives. I think Mamapudi can comment more on the TB modeling, direct TB modeling initiatives and what might be available on the African continent. But there are also wider modeling groups. Some of them are disease specific, like you've got malaria modeling consortiums and AMNET, which is the Applied Malaria Modeling Networks. Whilst they may be malaria related, they have a lot of many resources on modeling in general for people who would wish to learn more about modeling and how to engage in modeling. There's also another network called there's a neglected tropical disease networks for modeling, and there's a wider modeling network called Modeling for Disease in Africa. Modeling for Disease and Health in Africa, I think it is. It recently changed its name. And that particular modeling group is also dealing with across a range of diseases, and TB may be one of them as well, and that would also be a good group to be tapping into for anyone who wants to who's interested in modeling.
All right, brilliant. Thank you very much. And Mamapudi, I don't know if you want to come in here with regards to some of the work that's going on regionally, the coordinated efforts.
Yeah, I was gonna say, so for TB specific modeling groups, there's the TB Modeling and Analysis Consortium, which is a global consortium of modelers from all over the world. So South Africans and Americans and all the Europeans are joining on that platform to generate modeling evidence. And it covers a lot of things. So I think that it is a good resource or a good way for people who would want to get into or just be aware of what's happening in the TB modeling space. So I've shared the link and people can access it. Yeah.
Thank you, Mamapudi. And I think the link has gone into our panelist chat. So maybe if you can share it to everyone, Mamapudi, that would be excellent. All right, and I think just quickly, Sheetal, before we move on, the burning question on everybody's mind: can everyone access the VaxSim tool?
It's just a teaching tool. It's very simple. I'll actually just put it up onto our website, and then it'll be, and I'll share the link with the group. But just to say, because just to remind everybody, it is a teaching tool. It's not a TB model. It's just a general tool, and the code is also accessible, so it's also easy for people to play with and understand assumptions as just a way of exploring uncertainty or understanding how models work. I think that's the point of it being so simple, is just to help young modelers or early career modelers also understand just how models work. Yeah, thanks.
Excellent. Thank you so much, Sheetal. And we're surprisingly, we're doing very well on time. And right now we're towards the tail end of the program. And I believe Petronella is online, excellent, to take us through some feedback that I would like to get from the group's end as we try to better understand the support that we at the NITAG Support Hub can keep providing to our NITAGs and our broader immunization stakeholders. So over to you, Petronella.
Thank you so much, Edina. Good afternoon to everyone. So my name is Petronella, and I'm part of NICHE as the Monitoring, Learning, and Evaluation Specialist. So my role for today is very simple. So I'd like to thank you all for joining the webinar, but more importantly, for our learning and monitoring processes, would really value your feedback on today's webinar, because it helps us understand your experience, what went well, what can we improve in future sessions, and what should we consider, like topics we can consider or support we can consider for future webinars. So in front of your screens, I'm hoping you can see the poll. It's very quick and easy to fill in. I think about 4 or 5 questions, which will take you roughly 5 to 6 minutes. So please take your time to respond to the poll, and let me know if with the thumbs up, if you can see the poll on your screen. Thumbs up if you can see it. Thumbs up if you can see it. Can you all see the poll?
Yes.
We can.
Great, great, great. So please fill it in. Please fill it in. It will take you roughly 5 to 6 minutes. As we end off, we'll really appreciate your feedback and your reflection on your experience of the webinar today. Remember, there are no right or wrong answers. We are interested in your honest feedback. And we encourage everyone to just take a moment to complete it before logging off. And just to reiterate that your feedback is important to us and will directly inform how we design and deliver our future webinars, as we want to have them every quarterly. If you have any questions, please let me know. but I'll take this moment to just give you time to fill in before Tony comes in to wrap up.
Petronella, I think there's a question from the group.
Yes, please go ahead. Is it Ian? Feel free to speak. Deanne, feel free to speak.
It's Mamadou.
Yes,
Mamadou Dion.
but I can see it's in French there by the chat, and I'm not
Okay, maybe it's in error.
Interprefy. Oh, he's asking for the poll to be translated to French. Is it possible, Salim? I thought depending on how you join, you are able to see it in the language preferred. I'm not too sure. Please advise. Because I know Zoom should be able to translate it from your computer.
Yeah, I was
Yeah,
asking for the QR code to be displayed once again. Couldn't see it.
the QR code for the...
That provides the link to the questionnaire.
It's actually a poll which pops up by your screen. So I'm not sure, maybe they closed it by mistake. Salim, can they reopen it if they closed it?
Yes, it's available if you click on the poll function at the bottom of your screen.
So just to say on my screen, what's coming up is webinar 18 mathematical modeling poll, but then it doesn't show you the questions, but at the bottom, there's a little box that says get QR code. And if you click on that, the QR code will pop up. So you can try that.
Okay, thank you so much, Christine. I hope that's clear to everyone.
No, Christine, you're seeing that because you're a panelist.
Oh, okay. Apologies.
But for everyone else, it should be a poll and it should be visible on your screen unless you closed it or you minimized it. So if you go to more, there should be if you go to more, so under polls and quizzes, you should be able to see the poll there. All right, I'm gonna hand it over to Tony while everybody finishes off. But thank you so much to those that have responded so far.
Thanks, Petronella. So I've got 0 minutes to end off. I wanted to make 2 points and to make one suggestion. And I think the points are good news points. So there's lots of bad news in the world at the moment, but these are good news points. So the first is that we've heard from, starting with Alex and many others, that there's lots of good news around TB vaccines. I think those of us who've been around a while can remember, 25 years ago, we were talking about a new TB vaccine, and now we're still talking about it, and the current one is over 100 years old. But there's real progress, and there's lots of cause for enthusiasm and for optimism. So that's really good, considering the huge burden which TB places on our communities. So that's the first bit of good news. The second bit of good news, I think, came from Mama Pudi and Sheetal, and that is that modeling is not some form of magic. It's an available tool. It's accessible. It's not hocus pocus, and there are ways, and there are modelers who are very keen to help us make our decisions and support the evidence that we need. So I envisage that it's going to become more and more routine in all of our decision making, and hopefully, today's webinar has turned all of us into modeling enthusiasts and modeling champions, because we need to get the word out there that this is a very powerful tool, and should and can be used for the work of NITAGs. And then the thought I wanted to leave you with, I took notes during the webinar, and there was so much good stuff, and I'm looking forward to going through the slides in more detail. But the one slide which I think will stick with me is the one that summarized that Wasila showed us, which really showed us the contribution. It was entitled Incorporating Modeling in Grade ETR. And it shows you just step by step the contribution that modeling makes to the whole ETR process in terms of problem priority, benefits and harms, etc., all the usual domains. So where does modeling fit into that? And for those of you who are NITAG members and NITAG chairs and so on, I'm sure that will help you defend the use of modeling evidence when you are looking at using it to inform your decisions. So I'm not going to say any more than that. I just, in ending, thank you very much to our moderators, to our speakers. We're so privileged to have such high quality inputs, and also to all of you for making time to attend. And I've been asked to tell you that the next webinar is on the 24th of June the 24th. Of this year. It'll also be on mathematical modeling, but not necessarily on TB vaccines. So we look forward to that. That's in about 2.5 months' time. So thank you all very much, and well done to the organizers on what I thought was an excellent webinar. Have a wonderful afternoon or evening wherever you are. Thank you. Good night.